So good afternoon and welcome to the fourth session this week of our online bite-sized lunchtime learning sessions as part of the Greater Manchester Falls Prevention Awareness Week. Just a reminder as well, today's session will be being recorded and will be available on the GMCA YouTube channel by the end of this week or early next week at the latest, and all the slides as well will be shared with you so you can share those with colleagues if useful. Thanks everyone for joining. Really appreciate your time today. We've got three brilliant speakers. So just a quick overview of the agenda. Firstly, we've got the Falls Exercise Implementation Study, so the FLEXI study, and some of the emerging insight across Greater Manchester. And Dr. Jodi Ventre from the University of Manchester is going to be taking us through that. We've then got Sarah Harris from Northwest Ambulance Service, who's going to take us through some insight into their programme of work. And then finally, we've got Megan Brown from Manchester City Council, who's going to take us through a falls prevention project that happened in Greater Manchester. Just a quick overview of the format. So each of the speakers will have sort of a 8 to 10 minute presentation, and then following that we'll have a short Q&A for any sort of burning questions, and you can continue to ask questions in the chat as we go, and I'm sure the relevant speakers will be able to respond accordingly. But if there are any questions that do go unanswered in the chat or as we go, I'll take those and contact the speakers directly and get back to you if that's okay. So I'm now going to hand over to Jodi, who's going to take us through the first presentation. So if you just let me know when you want me to move through the slides, that'd be great. Thank you.
Yep, no problem. Thanks, Beth. So hi everybody. So as Beth said, so my name's Jodi and I'm a research associate at the University of Manchester. And today I'm going to be giving you a really short overview and some initial emerging insights into the FLEXI project. Next slide, please, Beth. So for those of you who maybe aren't aware of FLEXI or FAME, FAME is just the evidence-based 6-month exercise programme aimed at reducing falls in the community. The provision tends to be delivered in a group-based format, and it's a face-to-face model delivered by qualified postural stability instructors. And this is really with the aim of challenging the balance and improving the strength of older adults. So over the last 18 years, FAME has been reciprocated in terms of it's been reducing falls and it's been showing its benefits of increasing strength and balance in older adults. But the adoption's been somewhat limited. So really the study wanted to aim to look at the spread of the programme further. Next slide, please, Beth. So the aims of our FLEXI study were therefore to understand really how best to increase the spread of FAME across mainly 3 geographical areas across the UK. So today I'm going to be giving some slightly more detailed emerging insights into Greater Manchester, but we have also worked with sites in the East Midlands and Devon. We wanted to assess the role that the FAME toolkit played in increasing the availability of FAME across those locations, as well as really tapping into the participant experiences of attending those FAME classes. We actually wanted to further review the provision delivered in Greater Manchester as well. So in partnership with Later Life Training, we have actually looked at the quality and fidelity of their delivery to the evidence base. Next slide, please, Beth. So at the very start of the project, we actually asked the 10 localities across Greater Manchester to submit expressions of interest in order to work with us further on this project and in order to examine their FAME provision. Fantastically, we did receive expressions of interest from all 10, which was really great. And unfortunately, we could only actually take 5 further for the actual research study. So of those 5, which you can see underlined on the slide here, we actually were able to work with Trafford, Manchester City, Bolton, Oldham and Rochdale. Next slide, please, Beth. So in terms of data that we collected to meet our aims, we actually conducted 45 interviews across all of our sites. So these were with key stakeholders to the implementation of FAME, alongside the individuals, the postural stability instructors who deliver FAME, and then those who attend those FAME classes. We collected something called a minimum data set, which simply is just the information collected by each of our sites in terms of the classes that they deliver. So this helps to identify participant progress, as well as being able to demonstrate the effectiveness of the programme when they come to an end. As previously mentioned, in partnership with Later Life Training, we have conducted quality and fidelity observations across 10 separate classes in Greater Manchester in order to examine their delivery in greater detail. and really to be able to provide them with support and feedback in order to really adhere to that evidence-based delivery. We've been able to collect some health economics data on the costs associated to implementing and delivering the programme. And lastly, we conducted 2 separate independent workshops with Greater Manchester representatives from a variety of backgrounds, really to update our toolkit, which I'll go into on a later slide. So next slide, please, Beth. So I really just wanted to get into the our initial findings for you, and the reason why we've said it's really emerging insights is we're still almost doing this analysis at the moment, so these aren't the full and final findings. But one of our initial questions was into the spread and adoption strategies that have worked previously in order to try and get more sites and more FAME classes up and running across those 3 geographical areas that I've mentioned previously. So we did this by analysing just 25 of the interviews that we conducted. So these were with stakeholders and providers of the provision. And it really became clear how at the very start of this implementation journey and the process of getting FAME into practice, high-level leaders were really imperative to being able to commission this process. So it really was us trying to work out and identify who were the individuals with the capability to sort of drive this fall prevention agenda forward, and that really did start with these what we term as high-level leaders, sort of commissioners, to be able to champion that fall prevention agenda. We did also identify that we needed implementation facilitators. So basically, these are the individuals that are able to lead and understand the service requirements practically and how to be able to deliver them from a service perspective. And then lastly, we spoke to postural stability instructors around delivering the evidence-based programme. So without these individuals, obviously the programme doesn't go ahead and individuals don't get to experience those classes. But really we were trying to tap into determining the realities of working in somewhat an unregulated industry. And really we found that the retention and training of our PSIs came through as something that we really need to support in research and in order to basically facilitate the successful delivery of the programme. So I think this slide is really quite nice in highlighting that really falls prevention is everybody's business, and I think there is a part that we can all play in terms of getting FAME provision into practice. So next slide, please, Beth. So for those of you who aren't familiar with FAME and its supporting documentation, the toolkit essentially acts as a how-to guide. So basically anybody should be able to access this documentation right from commissioning levels and making the business case right through to you being maybe an older adult that actually attends these FAME classes. So similar to some of the health economics data that I mentioned earlier in terms of the cost of implementing the provision, we actually are updating both that and the toolkit in general. So we conducted 2 independent workshops with 15 participants across Greater Manchester, of which 7 of the localities were represented, so that was really great. And we asked those individuals to review the toolkit prior to those workshops and think about the following questions that you can see here on this slide. So really what worked about the toolkit and what worked less well that we need to really focus on. Next slide, please, Beth. So you can really start to see some of the feedback that we received here, and we were really pleased that the feedback was overwhelmingly positive. Everybody found the toolkit to be an effective educational tool that sort of provided appropriate resources for all of those job roles that I've mentioned earlier. And we do really want this to be a tool that at any point in the implementation of FAME journey, you can kind of go to this toolkit and kind of pull it off the shelf if you like. And it is actually divided up into sections that are most relevant to each of your experience. So this is really just a tool to give you guidance and resource relevant to the falls management exercise programme. But the workshops did highlight a number of improvements which we're currently working on, and these were really centred around the need for local and specific information. So I think it's really important across Greater Manchester that we're able to provide this support around accurately mapping these services and acknowledging local differences that actually really affect our implementation. And we see vast differences really between the Greater Manchester landscape and that of maybe more rural Devon. So it's going to be important for us to embed some of that into our toolkit. We're also trying to focus on some more detailed examples of how FAME sits into that wider falls pathway. And as I say, we're currently working on these suggestions, and we can't wait to share the updated toolkit with you. Next slide, please, Beth. I think one of the most important aspects of the project really was speaking to class attendees who actually experience the FAME provision which happens across Greater Manchester, the East Midlands and Devon. By speaking to these individuals, it's been able to provide us with an opportunity to see what would really maximise their experience and increase adherence. What we mean by this is, we want people to repeatedly go back to the offer which they're being given across Greater Manchester and access these classes. The evidence base currently sits at that we need approximately 50 hours of engagement with these programmes to reduce fall risk. So if we see this sort of like ad hoc adherence because of some of these factors, hopefully this is something that we can kind of mediate to help participant experience. So I'll just run through some of this feedback because I'm conscious of time, but participants really appreciated the social opportunities that were provided by the classes in which they went to. When we spoke to commissioners previously, we're aware that we need almost a new holistic approach for FAME and to really highlight the additional benefits that implementing these classes can offer. So social interaction was a really motivator for attendance, but actually also reduced social isolation, which was a really good benefit to see. We specifically spoke to some male participants because we know that adherence and attendance to these classes is predominantly female, and some males expressed maybe a potential interest in male-only classes, and this was really just to be able to exercise with people who are more representative of themselves and their capabilities. Surprisingly, some older adults didn't actually receive too much feedback on their progression. So they would almost start a class and end a class, whether that be an 8, 12 or 24-week offer, with very little verbal or written feedback on their progress. So they welcomed that. But what we did really see was that the rapport with the instructor was really important. We see that obviously there's some classes in Greater Manchester that have a free offer and then they go into a paid transition into maintenance. And keeping the postural stability instructor the same for both of those classes really helped people continue to exercise. Next slide, please, Beth. So as previously mentioned, we wanted to work with the Later Life Training Organisation, which is actually the organisation set up by Professor Dawn Skelton. And basically, her instructors and assessors came out across Greater Manchester and looked at the 10 different classes independently of their quality and fidelity. So the reason why this was important and these metrics was because sometimes interventions such as FAME appear ineffective, but sometimes it's often just that they're not being delivered to the evidence base. So what they did is they have a criteria in which they provide deliverers of a quality score out of 24 and a fidelity score out of 57. So this is really looking at how the delivery meets that evidence base, which was previously set up those 18 years ago. So as you can see from the graph here, it might be quite small, and I apologise for that. Greater Manchester sites actually account for the purple dots. So as you can see, there is really a range of quality and fidelity scores of provision, and each individual site that has had a visit has been supported by Later Life Training on how to improve those aspects. But I just thought it was nice to report that we do have one of our particular sites scoring the highest quality and fidelity of all of our Manchester, Devon and East Midlands sites. So there is some really great high quality and fidelity provision going across Greater Manchester at the moment. Next slide, please, Beth. So I just wanted to really point out some of our areas of success. So this is really in relation to Greater Manchester specifically. So some of these were sort of like the appropriate screening of falls and associated injuries, which was really important when individuals enter a class. And this really helped postural stability instructors to be able to select appropriate speed of exercise and delivery to meet class needs. I think this is really important that when individuals enter the class, they feel like the class provision adheres to the evidence base, but also is appropriate for how they're feeling at a particular time. And that really helped our instructors across Greater Manchester build the rapport with class attendees, which class attendees then have reported in those previous slides at how they were motivated to keep them coming to the class. Particular areas for improvement across Greater Manchester is this idea around allowing individuals to become educated to exercise independently. So what we don't want to see is that sort of the money is being used for the implementation of FAME, and then individuals are re-entering that cycle once they've finished that FAME 24-week provision, for example, because they then go back to not exercising once they leave those group-based classes. So it really, the areas for improvement really were around reinforcing those teaching points and explaining the purposes of the exercises and how they can be conducted sort of in everyday lives at home, so that once an individual has been through a FAME class, they're then able to exercise independently and safely at home. Next slide, please, Beth. So I know it's been a really quick talk with a lot of information, but I think what the main take-home messages are is that at the very start of the FAME implementation journey, it's really imperative for us to have that buy-in from high-level leaders and commissioners. And this is really just to increase that implementation of evidence-based fall prevention programs here. I think the improvements in quality and fidelity on the previous slide enable the postural stability instructors to deliver to the evidence base, and that really indirectly improves adherence of the programme, so it keeps people coming back and seeing the reduction of those fall rates across Greater Manchester. We just need to continue to assess class attendees who attend FAME classes to ensure that they really are the right people for the right FAME class at the right time. And we can do that by improving the fidelity and quality of the programme. And then the last point I'd just like to make is that we are working across GM to look at follow-on provision and maintenance. So this is just to continue individuals exercising more independently and to stop them re-entering these programs after secondary periods of deconditioning. So then that just takes me to my last slide, Beth. So I just want to thank the wider FLEXI team, of which it is really large, but really just want to thank the GM sites that we've worked with specifically, because they have really worked tirelessly to provide data and be involved in this process. So without them, it wouldn't have been possible. So thank you very much for your time.
Brilliant. Thanks so much, Jodi. Great to see the progress and development of the programme, because I remember having an initial conversation with you when we were first starting up, but great to see as well the recommendations for the toolkit as well being implemented. That sounds great. I'm just going to open it up briefly to any thoughts, comments, questions for Jodi. I think there are a couple in the chat, so I'm just there's one from David. Which type of organisations were the high level leaders?
Yeah, so these actually really sat embedded in every single organisation, really. So it was more whoever your commissioner was for your particular where you went to for your public funds in order to be able to implement FAME specifically. So what we're trying to suggest is that we have sort of those high level leaders in each of the localities that you're aware of, that you're able to go to and have these discussions about falls prevention agendas further, basically.
Brilliant. Thanks, Jodi. And I think Chris has also asked a question. How can we help move those providers who score more poorly on quality and fidelity to score as high as best? And perhaps perform rather than score would be maybe a better way to describe it. I think Chris has added there.
Yeah, I agree, Chris. Yep, so basically that started with the later life training observations in terms of highlighting those things where they were successes and then maybe weren't scoring as highly. And later life training is actually put in place a community of practice now. So they meet regularly to discuss these issues and provide guidance around how to change your provision. But one of the single biggest things that came from the quality assurance visits were that often as a consequence, of the COVID-19 pandemic, we've had a real problem with deconditioning, and actually that very initial assessment into who enters these FAME classes was really imperative, because often we're seeing people with not the capability to be able to perform the exercises to the evidence base. So that was bringing those scores down. So I think it's just increasing awareness and being able to be supported from both a research and later life training point of view about who needs to be in those classes, and then who then subsequently receives that intervention.
Yeah, definitely. What was the association in terms of the amount of commission each area had to deliver the programme? Were there vast differences in the level of commission, and did that then impact, obviously, the fidelity in the way that the actual programme could be delivered? Because I know, just anecdotally from speaking to a number of areas, I think Trafford, for example, would really want to deliver the full programme, but don't currently have the commission to deliver the number of weeks. And did that play some impact, or have an impact, sorry, in that?
Absolutely. Yeah, so it's really varying across GM, and maybe those are some figures that I can share with you all actually about how many classes actually do sit in each of the localities, because they're very different. So Manchester City, for example, are Manchester Active now, are a huge provider of postural stability and FAME classes, whereas Rochdale, for example, have a smaller access to a funding pot, so deliver on a smaller scale. So I think that it does really affect, because sometimes we see the increase of number of classes, but actually the reduced number of weeks. And we know that obviously 24 weeks is the evidence base. So we start to see the delivery of both 8 and 12 weeks. So they will be contributing to that 50-hour dose that I mentioned earlier about the benefits of, people engaging in this type of activity. So there's definitely things that we can do. And I suppose it's the argument of how many people have access to the service in respect to then how many people actually go through the full 24-week programme. So often what we're seeing across all of our sites, so that's the East Midlands and Devon the same, is that we tend to have more classes in shorter duration. But a way to combat that has been maybe a 12-week free offer and then a 12-week paid offer. But then we've got some motivators for the continuing of that in terms of keeping the instructor the same and other methods that we can use. So there are things we can definitely do to adhere more to the evidence.
Brilliant. That's been incredibly useful. I think we've got one final question from Sue. When is the FLEXI study due to be published?
Perfect. So we're writing all of our publications now, Sue, and we are making the changes to the toolkit, and we're hoping to have them completed before March next year, but hopefully by the end of the year. So
brilliant. Yeah. Not too long to wait then. That's great. Well, thanks again, Jodi, for your presentation. That was brilliant. I'm now going to move us on to our second speaker. So we've got Sarah Harris from MWAS, who's going to take us through a presentation of the work happening on your programme. I'll hand over to you if that's okay, Sarah. Thank you.
No problem. Hopefully you can hear me.
Yeah, we can hear you fine.
Just going to talk a little bit about the work that we're doing across MWAS this week. It's not MWAS covers Greater Manchester, where my focus is, but we've got work. This piece of work is being done across Lancs, Cumbria, Cheshire and Mersey, because that is our footprint. So I'll give you a little bit of a background and one of the reasons why we chose the Falls Prevention Week to do some of this work. So if we could have the next slide, please. So falls are one of the leading causes of emergency calls in the over 65, and they account for, depending on different trusts, between 10 and 25% of our emergency responses each year for patients over the age of 65. And as we know, with the ageing population, these calls are only going to increase. Falls have been identified by ambulance services as one of the patients that really contact us the most. So we might go out to a patient one day for a fall, and then we often will go out to them again the day after or the day after. So they're a very they use the service for 999 calls a lot. As we know, falls and falls related injuries are associated with increased morbidity and have impact on quality of life, health and healthcare. And it's important that as an ambulance service, we start to assess the assessments that our ambulance clinicians provide to this patient cohort when discharging at scene. And that's the cohort I'm going to talk about to help us improve the care of these patients. And this links through to the MWAS strategy of trying to deliver right care at the right time in the right place every time. So that's one of the reasons for the piece of work. So next slide, please. So if I just give you a little bit of background about how ambulance paramedics and ambulance technicians sort of come to decisions, and we have guidelines which are written by the Joint Royal College Ambulance Liaison Committee called JLCalc, and there are guidelines on everything from falls to cardiac arrest, etc. So there is one on falls in older adults, and I'm going to come back to this one, but this one talks about, and each guideline has talks, I've put on the screen, they have an introduction and talk a little bit about each subject, and then come up with an assessment and management plan for each type of a clinical presentation. And JLCalc talks about the intrinsic and extrinsic causes of falls, and this will now links to a new ambulance quality indicator that I'm going to talk about. And behavioural reasons why a patient might contact 999 after a fall. So next slide, please. So within the ambulance service, we have some ambulance services across country. We have some ambulance quality indicators, and these are were created to provide an overview of system performance and clinical quality achieved by each of the ambulance services. There are 4 clinical quality topic areas which each ambulance service has to report on, and each of these has a specific clinical process and outcome measures, or a care bundle as we call it, for each subject. So up until very recently, it's been cardiac arrest, ST elevation MI, stroke, and it was originally, until about 3 months ago, sepsis. This sepsis has now been replaced by older adults discharged at scene. So that is now what we're going to be auditing across ambulance services, and it covers patients over the age of 65 who fell less than 2 meters. And are discharged on scene, and that's the inclusion criteria, and there are some exclusion criteria as well. So the next slide, please. Oh, and you'll have to flip on. So as I said, it's for patients over the age of 65 who've had a fall from below 2 meters, and what the care bundle says is that each of these patients should receive a detailed physical examination, and this should be documented on the PRF, or the patient record. MWAS have had some challenges recently, and we've gone electronic, and we're overcoming some of our challenges in that org staff have recently been given iPads, and hopefully some of these challenges will be overcome digitally. But the 6 areas within the care bundle that are then audited by our audit team. So as I said, the first one's a detailed physical examination. The second, a detailed medical history is recorded. Current medications are documented. Observations recorded of the patient. A 12-lead ECG assessment is documented, and this goes back to the previous guideline where it talks about intrinsic and extrinsic causes of falls. So it talks about that 12-lead ECG should be completed on all patients where it is a likely intrinsic reason for a fall. So, for example, postural hypertension or other medical conditions that may have caused that patient to fall. It also talks about checking for a postural hypertension check, so a lying and standing blood pressure, and that should be part of the full holistic falls assessment of a patient that falls into this criteria. So if you just put just flip onto the picture, thank you. So they did some pilot results on the audit, so they looked at the patient records. And what we found was there was an overall low compliance in the care bundle, and I was working with the audit team around what we could do to try and increase compliance to the audit bundle, and increase then our assessment and improve our assessment and management of these patients. And one of the things we identified through audit was that crews were not necessarily, or our clinicians were not necessarily doing 12-lead ECGs and postural hypertension checks, or they weren't documenting it because of digital problems that we were having at the time. So we came up with a improvement plan to try and improve this across the trust. So next slide, please. Yeah, just flip through to, yeah. So what myself and the audit team was, we had a bit of a look on on the internet to see, was there anything going on nationally that could be done to that we could link into around falls. So and what we found was that there was this Falls Prevention Week, and we felt this was a really good week where we could focus some of the work that we were doing and have a focus across the trust. So we presented it to our one of our board meetings, and they agreed that we could for 1 week have a focus on falls throughout the trust to improve the assessment and management of these patients. So we came up with a plan, and there's a whole plan on a page for it, and smart objectives of improving compliance to the audit over the till December and then into March next year. And we looked at linking into Falls Prevention Week, and I'm currently on a Falls campaign roadshow with local champions across Greater Manchester, visiting ambulance stations and local emergency departments, talking to crews about everything fall related. So how we assess and manage our falls patients, intrinsic and extrinsic factors, because what we found was through conversations with clinicians, they weren't necessarily understanding the difference between intrinsic and extrinsic. We're talking about how to properly measure a line standing blood pressure, how to document that on the patient record. And we produced some cards and some leaflets that we would give out to crews, and we talked to them about the new falls quality indicator and what we can all do to help with the assessment, management and falls prevention in our patients. As I said, we've produced a pocket card within MWAS. It is my next slide, but I'll show you that in a minute. We have something called Rapid Recap that one of our advanced practitioners has developed, and it's a monthly 2-minute snapshot to education. The problem, or not the problem with being a paramedic is you really do have to be a jack of all trades. 1 minute you go into a fall, your next job might be delivering a baby, or it might be a cardiac arrest. So and everyone within our trust, we all have different interests. My interest is falls and frailty, and what we rely on is those sort of individuals to go out and promote what their interest is in, and this rapid recap gives us an opportunity based on key themes within the trust to promote education to our clinicians. And so we looked at, last month we did a pre to this week on frailty, and then this month we did a rapid recap on falls. We also have another group of advanced practitioners that every month produce a document with key learning free document research articles that our crews can read and go out and have a look at. And then what we're going to do is measure through audit the success of all the different interventions that we've done. And then falls is also going to be now added into our winter plan around some messaging around falls prevention. I know we're working with Beth across GM about what we can do around joint messaging to what MWAS can do around falls prevention. So next slide. So this is our rapid recap. So this was the frailty one that we had. These go out once a month to our crews. It is literally a 2-minute snapshot of education. What that is sent out. We have digital boards all around our stations to try and raise the profile of a particular subject. So this last month it was frailty, and of which falls is one of the frailty syndromes. And this month we did one on falls. So next. Thank you. So the falls one, and we concentrate on, we do the what, so what, now what. So what is the problem? So we talked about intrinsic, extrinsic falls, the fact that falls are very likely in older adults, and then we give them some anatomy and physiology. And there's so much data we could have put on this, but we concentrated on orthostatic hypertension. One of my colleagues did a QI project on this. So we talked a little bit about why it's caused and then what we want our crews to do. So we concentrated on getting them to think about intrinsic, extrinsic and behavioural causes of falls, getting them to refer to our JL Calc. JL Calc is sent out to all crews. We have it on an app on our phone, on our iPads, and all our guidelines are there. And then we got them to think again about how to assess a line of standing blood pressure and document it, and how to document it. And then next slide. And we've also produced some education around falls and falls awareness. If you next slide, sorry. So we've done a leaflet for our staff around falls top tips and how to assess what the AQI is, so they have an understanding of what they're going to be assessed against. Gave them some links to falls and falls advice, escalation advice, and then we've also provided, if you press next slide, our out of hospital CPD talked again. We found an article which was relevant to the subject that crews could read as well. So we've really focused on that education, and then we're going to see whether through audit that education has made a difference to our care bundle. And I think that's the last of my slides. So it's an ongoing. It is very much work ongoing on project. And it's been a very wet week. We've been stood outside multiple emergency departments, getting rained on, talking about falls and falls prevention.
Oh, brilliant. Thank you so much, Sarah. There's so much detail in there, and great to see so much education and resources that you're being shared across the workforce. I'm just going to check the chat before I open it up to any comments or questions. I don't think we have anything in the chat at the moment. Anyone got any comments, thoughts, observations for Sarah?
We've also been linking in with some of our crisis response teams. So this afternoon we're going to Wigan ED, and they're going to meet us there. We're going to talk about what happens when falls our crews do a falls referral, because often they don't appreciate the guidelines behind the referral and what will happen when there's a referral. So our crisis teams have been joining in to sort of try and prevent the falls as well, and get crews thinking about that fear of falling as well. And often patient might not have fallen, but a falls referral might still be appropriate for them. So that's what that's what we've been focusing on.
Brilliant. That sounds fabulous. I'm going to bring in Trish. Have you got your hand up?
Yeah, I do. Just is this being shared with other ambulance services, or will it be when it's finished, or is it intended to do?
We're hopefully going to present the work that we've done when we've finished and through the audit. We have a national ambulance conference every year, so we're hoping, if there's a success, that we will present it there.
No, I'm curious, as my daughter's studying at the East End Norwich at the minute, so I'll fire this information on to get her to keep an eye out for it.
Great, thank you.
Brilliant. Yeah, it'd be great to see do you know when that sort of timeline the audit will be?
So there's an audit due now. So the audits are done 4 times a year. There's an audit due now, and then we've got the audit in December and then March, and then we'll look at the data then.
Brilliant. Is part of the existing sort of pathway and sort of service, do the ambulance service have information on sort of local provision of, it might just be physical activity, or if someone might be at risk but may not have had a fall? Is that kind of information shared?
It can be really complicated being a paramedic, because you could be a paramedic based in Cumbria and you do a transfer of a patient from a hospital in Cumbria to the centre of Manchester, and then you end up, your next job might be a fall, for example, in the centre of Manchester, and you don't know the area, it's not your area. But we have something called Service Finder. So all our local urgent crisis response teams, our social prescribing, our falls prevention services are all linked onto this digital solution, and the crews would look at that and see what was there locally.
Brilliant. That sounds fabulous. Just a couple more questions in the chat. So Sue has asked, wondered how you're planning to share this with other ambulance services, and I know you mentioned the national conference. Is there
the audit team? There are national audit meetings as well. So with the audit team will share the work that we've done at these meetings.
Brilliant. And Chris has just asked how the programme is going. That tries to reduce onward referrals to A&E and identify how to support a person who falls at home and reduce the risk. I'll bring you in, Chris, if you like.
Hi, Chris.
Hi, I might not have said it very well, but I did hear about a programme which is very much more, rather than trying to reduce the amount of transfer to hospital and support people at home and refer sensibly to.
So there's a lot of work being done across the whole of MWAS, just Greater Manchester on improving. We have what's called hear and treat, which is the triage we do over the phone. We've got see and treat, which is the see the patient, treat them at home, refer them to the most appropriate service. And then we've got see and convey. So there's a lot of work being done around see and treat, and some of that is education. Some of those is linking into the services that are available. I'm doing a piece of work in Trafford. Trafford are about to, we have a crisis team there that are just about to extend all their service hours each day and over for the 7 days. So we link into these services and make sure our staff are aware of them, and education as well, and providing staff with. We use something called Manchester Triage. So our paramedics and our ambulance technicians will use the Manchester Triage system, which will help them make a clinical decision on their patient. Brilliant.
Well, thank you very much. Some great questions there, and thanks so much for all the content. I know someone asked in the chat around the slides. All slides will be being shared by early next week, along with all the recordings as well. So thanks so much, Sarah, and I hope your roadshows continue to go well.
It's sunny today, so I don't mind.
There we go. Okay, I'm going to now move on to our final speaker. So we've got Megan Brown from Manchester City Council, who's going to take us through the falls prevention project, if that's okay. Thanks, Megan.
Yeah, I'm going to talk to you about a year-long project. It ran from August 22 to August 23, and it came as a result of some deconditioning money that came available. And as an age-friendly team, so I'm from the council age-friendly. Well, at that time we were part of the NHS. We've now moved into the neighbourhoods team in the city council. Pre-COVID, we were running a series of falls prevention workshops, and we developed a falls prevention model. Over COVID, we obviously had to adapt, and that developed into, we produced a falls and balance DVD along with PARS team, physical activity referral scheme, and put together packs of falls packs, you might call them. They had DVD in slippers, exercise bands, and a range of nutrition and hydration and associated information. They were delivered via Good Neighbours groups to isolated people. So I'm actually presenting this on behalf of, this is Jade's presentation. She was the worker for the year. That was the funding that we got through. Okay, next slide, please. Thanks. Yeah. So this is just a bit of the context to the work. So we know that falls-related accidents cost the NHS over 2.3 billion a year. And as the age-friendly team, a level of understanding of the impact of fall in mid to later life on a person's ability to live and age well. So these were some of the context for the actual money as well. So going on to next slide, please. So we started from, we obviously had a model, a falls model. We had a new worker in post, so we were going right back into the community and taking that co-production approach. So we began with discussions with some of the larger groups, so Charlton Good Neighbours groups, Sound Heart Coffee Morning, and an age-friendly board to get their input really and feedback around this kind of topic. And generally, we found that residents didn't agree with the don't mention the F word. They kind of wanted this workshop to be call a spade, you might say, and you wanted clear and upfront language. That was something we took into account. They also highlighted digital inequalities around health information, and they wanted it to be presented in a way where they could ask questions, and suggested that exercises as part of the sessions would be useful too. Okay, so next slide, please. Thanks. So this is just some of when we're looking at the reviewing the literature, some of the evidence that we reviewed. Okay, won't go into that one. Next slide, thanks. So this is when the workshop started taking shape now. We were lucky that Jade it wasn't actually in the job spec, but she was an OT, so she had that OT perspective, which was really, really useful. We knew that signposting needed to be a part of the workshops, follow-ups, the key messages, and the walking stick MOT, that practical element, which is also a good way to start conversations about mobility. So walking sticks will be checked for safety, the correct height, and ferrules changed as needed. And we had ferrules there and then, but they could also be signposted to services to get replacements as needed. I'll go into the chair-based exercise and other elements a bit later on. Okay, next slide, please. So we're taking a population-based approach to this primary prevention. Obviously, looking at the risk register, we were probably working more on the lower risk end. So around education and exercise. So it was an educational talk. We have discussion, some physical activity built in, and highlighting local opportunities and community assets. For those with medium risk, signposted to PARS and other local opportunities, and higher risk, we did a lot of workshops in conjunction with the falls teams as well. So that could happen there and then, or a referral. I'll mention it a bit later on, but as we moved into the project, and the next steps been around working more with that medium risk group when we do some more targeted work within care homes and extra care schemes. Okay, next slide, please. So one important part, so we could give quality signposting, was also obviously gathering that information from local services. So when the work was in post, these are just a list of some of the places that we actually visited to get that information firsthand. So there's the aids and adaptation services, care and repair, the sensory teams, and the local VCS services as well. Okay, next slide, please. So as a result of that, we developed this signposting information, which was given out at the end of the sessions, so that the community groups or housing trusts could actually do their own signposting as well following the workshop. Okay, next slide, please. So this just shows some of the key messages and topics for discussion within the workshops, and you see a picture of the board that was kind of developed to give it more pictorial as well, because we obviously attended events and that kind of thing, as well as developing as well as the workshops, so might be invited to some community events as well. It just shows the breadth really of range. So it would depend on the group and the levels of interest and engagement, which of these that we kind of focused on. But the workshop included all those elements to kind of draw on. Okay, next slide, please. And we also had packs for people to take away, which we would kind of, this was the full list of kind of resources, but they would depend on the groups as well. So people got a tote bag, and pre-session as well, working with, depending on where the venue was, we'd find out before what local information in terms of activities and local based activity classes people could find out about, and they go into the packs as well. So it takes some time to find that out before the session. And we also, during the sessions, obviously, we did find out about gaps, which Manchester Active are now taking forward as part of their programme, and able to fund some sessions based on need. Okay, next slide, please. So we realised quite early on that this chair-based exercise element was an important part of the sessions. So we, so the worker trained up as a chair-based instructor and got level 2 qualification. So this just added a bit of those sessions where this was part of the workshop. There was a real lifting mood afterwards, I think, and it meant that people could trial out some of the exercise as well, which might make them more likely to then go on to classes themselves that they were signposted to. Okay, next slide, please. So this shows how many workshops, this is kind of from the January onwards, so it was like 2 quarters really. So 38 workshops were delivered, 11 of which were delivered in partnership with the Falls team, 30 included an educational talk, some of them chair-based exercise sessions, walking stick MOTs, and then obviously some different referrals and signposting as a result of them, and lifestyle advice given as well. Okay. Next slide, please. It was a citywide project in Manchester. So we already had an idea when Jay came into post of some of the places we wanted to target. It ended up being quite evenly spread across the city in terms of workshops. So I think there were slightly less in North, but I mean that is also an area I think we would have focused more on further down the line, because obviously looking at those more deprived neighbourhoods to focus on as well. But we took a bit of an opportunistic approach to it, really, with it being a time limited post. So we worked in partnership with the Falls team. They attended 12 of the sessions, so they were able to add that other element to it. So we could incorporate blood pressure checks and referrals and reassurance there and then. And having a nurse or a psychotherapist there really helped as well. Okay, next slide, please. So from about February, March time onwards, we focused in more on housing schemes and extra care units. So that did mean that we're probably reaching less contacts, but you might say there were maybe those harder to reach and further up that risk register. So we did some work with Jigsaw Housing, a partnership project with Guinness Housing, and sessions at some of the extra care schemes as well. So as a result of the sessions, the kind of follow up from the Guinness Housing workshops, Manchester Active are now in the process of, or they might have moved on actually, setting up 3 regular physical activity sessions. So that will reach up to 60 residents. The Together Dementia workshops, that has led to setting up regular physical activity sessions as well. So it just shows some of the I think it highlighted where people were keen to do exercise, and you know that then it was good that Manchester Active could come in and take that forward. So feedback was gathered at the workshops. This was sort of given on a postcard, and people were asked to write one thing they've learned or something they'll do as a result of the session. And we got, I think on the next slide it shows some of the things people said. So they enjoyed the session, it was useful, interesting, plan to take action, knowing how to get up from a fall. Okay. And this just shows some of the evaluations from the Guinness House project. So 55% said they found the educational talk most useful. 80% said they would take some action, including doing more exercise or stopping smoking, keeping their flat safe from falls, or trying an exercise group. And 28% said they'd like more of the session. So I don't know how I'm doing for time. I thought I'd run out of time by now, so I wasn't particularly going to go through the case study. But
I think we've got a couple of minutes, so we
okay.
can open it up to any questions, and I'm going to share the slides, so people want to read through the case studies. Would that be best?
Yeah, that's great. Yeah.
Brilliant. Thanks, Megan. Thanks for taking us through that. That's great. Any thoughts, comments, or questions on the project? I think we've got one from David in the chat. Is there any proactive preventative referrals from GPs or other stakeholders as part of the project? And also, were leisure centres engaged with providing solutions?
Yeah, so in terms of the GPs, they weren't linked into referrals because we were kind of visiting existing groups in terms of the workshops.
Mm-hmm.
But I mean, that could have been something to kind of take forward, and leisure centres, their sessions were obviously some of the information that they signposted to, But
Brilliant.
I mean, things like the age-friendly hours in libraries would have also been a good place to kind of go and deliver. It was one worker and a time limited, but it would have been a good one to kind of target as well. I think it's kind of, we're working to about 3 sessions a week. But seeing as the libraries have those age-friendly hours, that would have been a good group to go on to, I think. We're kind of working through our list of existing groups and places we knew would be good to target.
And has the
Yeah.
project been sustainable in terms of any of those approaches to directly contacting people and doing those kind of sessions? Are they able to be continued, or was it just a time limited project?
It was a time limited, so we were obviously we had ideas for if that funding was going to go forward, but I think it was kind of diverted to other things. But yeah, so I think in terms of obviously the activity sessions came up a lot, so that gap for people to keep moving and keep active, and particularly in the housing schemes and at all the workshops, I think because the session leaders were kind of there, they were able to take on that education and maybe take it forward that way.
Brilliant. I think David's got his hand up. Would you like to come in?
Yes, thank you very much, Megan and Bethany. Just following from what you've just said, Megan, you mentioned at the beginning that falls-related accidents cost the NHS £2.3 billion a year. I just wondered if local authorities, if they had an understanding of how much falls cost to their region, to their area per year, they might be more inclined to consider sustaining funding across a longer period of time.
Yeah, I mean, when first came into when Jade first came into post, we were looking to align more with care homes and that kind of work, but we realised the time it would take to get that inroads. We'd miss that time. But I think if that was one of the options at the onset, working alongside, and I know they were looking for an education program as well to go alongside. So, yeah, scope there.
Brilliant, thank you. Well, I'm conscious of time. We've only got 1 minute left. So I'm just going to ask one final time. Is there any other thoughts, questions, or comments for any of the speakers that we've heard from today? No? Okay, brilliant. Well, thank you ever so much to all the speakers. It's been great for you to come and share your expertise with us today. As I said, the recording will be shared probably by early next week, along with the slide decks from today. And if you're not attending tomorrow's session, it's been great to have you. But if you are, we look forward to seeing you again tomorrow for our final session of the week. And if you do have any questions, please do drop me an email. If I just reshare my screen with my email on, that'd be useful. Oops. Yeah, my email address is there. So if you've got any thoughts, comments, or feedback, that would be really useful. And we look forward to seeing you again soon. Thanks very much, everyone.